Hello and welcome to the Tuesday, April 14th edition of the Daily Situation Report for Thunder Bay Regional Health Sciences Center's COVID-19 response. My name is Tracie Smith. I'm the Information Officer with the Incident Management Team, and I'm here with Incident Manager Dr. Stewart Kennedy. Dr. Kennedy, our COVID-19 testing, our daily test numbers are much higher now than they were when we first started. Tell us about that.
Yes, Tracy, they are. I mean, we performed 54 tests in a hospital yesterday. That does not include the tests done in the community by our paramedic colleagues and some at long-term care facilities, but testing has increased. So it's increased because our criteria have been sort of readjusted to 2 or more symptoms. But that gets me to another point, actually, Tracy. The IMS structure, the incident management team, consists of over 100 leaders in this organization. And certainly they're here, the team is here to really protect the patients, but also to protect our healthcare workers and our first responders. And certainly we've faced some challenges. And some of the challenges we faced over the past week is timely turnaround. Our turnaround time has been 2 to 3 days. It's been extended to 4 or 5 days, and we've actually have talked with a number of individuals, organizations, and I think we have a reason why the turnaround time has been sort of expanded, and they have promised and committed that we'll improve that turnaround time to 2 days. But even 2 days is just not enough. We need to really have in-house testing. And all levels of government are working on it, that they realize our concerns, they realize our difficulty and not having the ability to do in-house testing. And let me give you an example. We expect over the next day or two for them to give us recommendations to increase something called surveillance testing, where they want to do testing on individuals with one symptom, like a runny nose, like a cough, like fatigue. If we don't have the timely turnaround at this point in time, we could be overwhelmed by sort of doubling, tripling, quadrupling our testing, and the impact of the hospital and our police force, our fire department would be overwhelming, because how many of us have a bit of runny nose during allergy season? How many of us have sort of a bit of a scratchy throat? If we had our workers come in, fail the screening process, that means even the city workers, even the police, the fire department, fail that screening, which many of us could fail just coming in. We could have potentially over 300 or 400 people off work for 3 or 4 days until we get those test results back. So I'm not recommending to go with the public health guidelines that are coming out shortly because of the backlog and the inability to care for our patients in the hospitals if I have half my workforce off. So from my perspective, we are being unable to follow the guidelines because we do not have in-house testing. If we have in-house testing, I can do someone can fail the screen, we do a test, they're back to work in 2 hours. We don't expose our healthcare workers to needless exposure to COVID-positive patients, and we protect our healthcare workers. So we can do a better job, both at the hospital, but we can do a better job at the ministry level and at the federal level to allow us to do in-house testing. I know it's a worldwide shortage. I know there's concerns out there about getting all the test supplies to us, but I feel Northwestern Ontario has a vulnerable population and should be given higher priority than I think has been given at this point in time.
Okay, so what you're saying is that you want to increase testing among healthcare providers, first responders, as well as community members. But there's an impact to that when we don't have the ability to turn the tests around quickly here locally. And that impact is not enough people working in the hospital or the police force, fire, etc. Is that the main concern?
Absolutely. We do need to do increased testing. I totally support increased testing because there's something called what we call containment. We feel in the North we've done a really good job at containing sort of COVID-19. But if we don't do the testing, we're unable to establish how good a job we're doing. So we need to do this. But to do this with just one symptom puts and turnaround time even 2 or 3 days puts individuals who fail the screen, which many, many will do, will have to be off work till we get those results back.
So the screen you're talking about refers to the screening at entrances to the hospital. So right now, if someone comes through and they have 2 or more symptoms, they cannot enter the hospital.
They cannot enter hospital. They're either sent home to do self-isolation, okay, or if appropriate, they'll be sent to the assessment center through the public health for a swab. Or that's the process right now. But you can imagine one symptom would actually exponentially expand how many testing we're doing. And the police and the fire, they're doing the screening too. And if they fail to screen, they would do the same thing, send to the assessment center, okay, through the public health, and they would do our swabs. We have capacity to do more swabs. What we don't have capacity to do is do in-house testing for a timely turnaround.
Okay, so you are continuing your efforts to get the necessary reagents and test kits here so that we can make that happen.
We are.
Keep up the good work. Thank you. That's great to really have that understanding. So moving on to the dedicated COVID care unit, things opened up yesterday. Can you give us an update?
Yes, I think things went quite well yesterday. I think there's always some hiccups when any plan comes to fruition, but certainly the team is ready. They were accepting patients, and as this morning they had 8 patients that's on the unit who are COVID positive or highly presumptive COVID. And the challenges we're running into right now is that we have 33 presumptive cases and we have 2 positive cases. If we put all those 33 presumptive cases into the unit, again, it could overwhelm the unit. So we have to pick and choose what presumptive cases we're going, the highly suspicious or the not as suspicious. And that's not easy to do. Again, if I had a timely turnaround with test results, I got them back in several days. They don't have to stay in that unit for 2 days. If I had in-house testing, I wouldn't have to send to that unit at all. So again, I think we're disadvantaged here by not having the ability to do the in-house testing. I mean, Premier Ford wants more testing. We want more testing, but we need an enhanced turnaround time so we're able to actually fill that COVID unit with appropriate patients.
So can you explain the difference between the presumptive cases? So under a presumptive case, there's a high suspicion and a low suspicion. What would the difference be, and why would someone be moved into the dedicated COVID-19 unit and someone else not?
So as you speak, we're working on those criteria, okay? The low suspicious is somebody who's come in with, let's say, recurrent pneumonia before, or has a history of recurrent pneumonia, and nothing has changed from their previous admission. To me, and they certainly have no travel history, but they have all the criteria for meeting the screening process, so they get a swab done. So again, and also somebody come in from an unknown population. It could be a homeless population or somebody who is mentally handicapped, can't tell us their symptoms. We're getting swabs on those individuals, but again, do they meet their criteria? Some meet the criteria, some don't, but they're swabbed because we're unable to get an adequate history from that group of patients. So that's how we have to sort of handle it for now. If we had the swabs, we could do the swab and get a timely turnaround. They wouldn't have to go to that unit.
Right. So a presumptive case, even if not moving into the dedicated COVID-19 care unit, would still be treated as if they were COVID positive in terms of PPE and...
Yes, and we're still doing all the PPE protection, no matter whether they're presumptive, no matter if they're low presumptive or high presumptive, we're still using all the PPE equipment. And that's another sort of hurdle we have to cross. We're using too much PPE, because again, we're not getting the results back in a timely fashion, so we have to take all those precautions regarding the presumptive cases, and so we're going through sort of valuable PPE to protect the healthcare workers, to actually care for the presumptive patients, sometimes for 2 or 3 days instead of 1 or 2 hours.
That's a really important point, that PPE use is not necessarily required, but we have to use it anyway for a number of days.
Absolutely.
Okay. You have mentioned that for the dedicated COVID-19 care unit, you've talked about the very heartbreaking reality that no care partners will be allowed. Can you clarify some questions that we're seeing around that? So what if the patient is a child or someone who requires assistance due to a physical or mental disability?
So this is a very difficult decision for the entire team, for our patient and family advisors. I mean, this isn't the way we like to do business, but we have a greater duty to take care of the community and take care of the staff on that unit and prevent spread. So certainly, but we're not totally heartless. I mean, we are opening up some selected rooms in pediatrics floor to have, if there's any COVID positive pediatric patients, they will certainly be allowed to into the pediatric unit, and we will have certainly one parent in there to help with that child. That's probably about the only exception, except the other exception is for palliative care. You know, there are going to be some exceptions for palliative care, but certainly these are very difficult decisions, but it's more to protect the community, and it's more to protect the other healthcare workers in that institution. So, I mean, a lot of different decisions are made to actually protect the public from a greater public health good than it is for a greater sort of personal care good, unfortunately.
Okay. So if there are really extenuating circumstances or someone with particular special needs, is it up for discussion with the care team, or is it an absolute?
It's as absolute as we can make it, but there's always exceptions that would come back to the administration on call to make individual decisions that balances the need for the family to be in close contact with special needs patients, as well as the potential sort of preventing any spread of the COVID-19 to other people in the hospital, other workers in the hospital, and the community.
Very difficult times and a lot of difficult decisions with it in that. We certainly appreciate everyone's patience and understanding as we work through all this together. And thank you for your ongoing dedication and the work that you're doing, Dr. Kennedy.
Thank you, Tracie.
Join us again tomorrow.